Hi, good afternoon, everyone. My name is Basavana Gowdra, one of the anesthesiologists at Thomas Jefferson Hospital. And we have two excellent and very experienced speakers. Dr. Phillips will go first, and he'll be speaking on anesthesia for endobronchial valve deployment and bronchial thermoplasty. And this will be followed by Dr. Mona Sarkis, who will be speaking on anesthesia for navigational bronchoscopy. As you know, there are not that many centers who do advanced bronchoscopy procedures, about 40 to 50 in the USA, to best of my knowledge. And navigational bronchoscopy is a relatively new thing. And of the other two, I think bronchial thermoplasty is kind of getting less popular than it used to be. Valves are still being used, not as frequently. So navigational bronchoscopy probably comes first, and Dr. Sarkis has been part of the study which made recommendation as to the ventilation parameters that are useful in patients undergoing navigational bronchoscopy to prevent atelectasis, which is one of the reasons that is responsible for low diagnostic yield. So she's going to talk about her study and talk about any recent recommendations, whether we still stick to those recommendations or modify them. And with that, let me invite Dr. Phillips to give his presentation, about 20-25 minutes, and followed by Dr. Sarkis, and then we will take question and answers. Thank you.
Good afternoon. It's a pleasure to be with you this afternoon to talk about some areas of interventional pulmonology, and I appreciate you taking the time to come to our presentation. So I'm going to talk a little bit about some of the anesthetic considerations for bronchial valve procedures, as well as I realize now I just put bronchial valve twice there, so we'll talk about bronchial valve as well as bronchial thermoplasty. So I don't know about y'all, but at our center, non-operating room anesthesia cases are taking on increasing prevalence throughout our operating areas and procedural areas. We now, probably on some days, around 40% of our cases can be in the NORA world. That includes, GI endoscopy, interventional pulmonary, cardiac EP, TEE, just a wide interventional radiology, of course. So, it's becoming more and more frequent. We're also seeing an increase in our interventional pulmonology cases at UAB. We recently just opened up a new procedural suite area for these procedures, and are seeing increasing numbers of interventional pulmonology cases. So significant growth in this area due to technological innovations, increasing demand for minimally invasive procedures. The global market for interventional pulmonology devices is projected to grow from about $6.2 billion in 2024 to over $10 billion by 2034. So as I say, an increasing amount of growth in these procedures. The technological advances such as robotic bronchoscopy, electromagnetic navigational bronchoscopy, the use of artificial intelligence to assist in algorithms for these procedures. We also are seeing a rising prevalence of respiratory diseases in the population and an aging population. So people are getting older and having more respiratory diseases, so the need for these type of minimally invasive pulmonology procedures. And also we're seeing more providers being trained in interventional pulmonology, and that increases the availability of these procedures. Dr. Gudra mentioned that there's not a ton of centers doing these procedures, but I think we're going to be seeing more and more as more providers are trained in doing these procedures. So bronchial valve procedures, it's endoscopic lung volume reduction. Endobronchial valves are deployed as a means of lung volume reduction in patients who have severe emphysema that's resistant to traditional therapies. Surgical lung volume reduction came about in the late 50s, And even with improving techniques, it still had a high amount of surgical morbidity and mortality. I mean, these are very ill patients who are having, when it first started, very major procedures. And so while it was done, it carried a high morbidity and mortality. As the availability and the development of endoscopic techniques for lung volume reduction were developed, it aims to replicate the surgical lung volume reduction, but in a much less invasive manner with less morbidity and mortality. Patients with emphysema have shortness of breath, very poor exercise tolerance. A contributing factor is hyperinflation. They have reduction in lung recoil due to damage to elastic fibers. Their chest wall elastance or compliance is preserved. In these patients, you see end expiratory lung volume, functional residual capacity, total lung capacity all increase, and air trapping occurs. So bronchial valves are one-way valves that block air entering but allow air and secretions to exit from the bronchioles. This renders that area of the lung atelectatic and diminishes air trapping. Decrease in the volume of the affected region may increase their overall lung elasticity, allow healthier regions to expand and function more effectively, and therefore their respiratory status improve, their quality of life improve, and have less respiratory distress. Candidates for the procedure are those who have severe hyperinflation and with a suitable lobe that can be rendered atelectatic, a lobe that doesn't have collateral ventilation or circulation, and we'll talk about that. This treatment received FDA approval in 2018, so it's a relatively new procedure. What are some of the patient selection criteria? A residual volume greater than 175% of predicted, an FEV1 less than 50% of predicted, no other significant coexisting pulmonary pathology, little or no collateral ventilation in the targeted lobe for treatment, and we'll talk more about that, clinically stable prior to having the procedure, and those who are without severe bronchiectasis. Of course, you don't want them to be severely hypercapnic or hypoxemic, and unstable cardiac disease would be an excluding factor. If they've had 3 exacerbations requiring hospital admission in the previous year, they're excluded, and of course, smoking cessation is paramount in these patients. They already have significant damage, and they need to be, bought into having the treatment done, and so smoking cessation is something that should be required. So both sedation and general endotracheal anesthesia have been described for bronchial valve deployment. General anesthesia is felt to allow better interventional conditions and reduced anesthetic time. It's associated with reduced coughing and less mucosal swelling, and allows more precise measurement for sizing of the valves. One of the keys to successful outcome in this procedure is selection of which lobe to target. There needs to be little or no collateral ventilation in order for the deployment of the valves to be successful. High-resolution CT is generally done in order to evaluate for fissure integrity as a surrogate for collateral ventilation. Patients are candidates for bronchial valve deployment if they have complete interlobar fissures. Our interventional bronchoscopist I was talking to says that he likes it to be at least 90%. An incomplete fissure allows air to pass from one lobe to the other, collateral ventilation, and obviously if you deploy a valve and there's still collateral ventilation coming from the other lobe, the ipsilateral lobe, then the technique is going to be unsuccessful because you're continuing to ventilate that portion of the lung in which you're wanting to render atelectatic. So limitations of CT, it's inconsistently accurate, there's inter-observer variability, and there can be collateral channels despite seemingly intact fissures. And there can also be things such as mucus blockage, valve placement, that may alter success despite having a favorable imaging study. So another method, in addition to using high-resolution CT, they use this Chartis pulmonary assessment system. It's a pulmonary assessment device that's used to directly measure the presence or absence of collateral ventilation in the lung lobe. You do a bronchoscopy, and through the working channel, you direct a balloon-tipped catheter that goes into the scope and is inflated to block the main airway of the potentially targeted lobe. So it almost looks like a little Swan-Ganz catheter, a little small balloon that you inflate. It blocks off that area. This is connected to a console that measures airflow and pressure from the occluded lobe. And if airflow from the occluded lobe gradually decreases and stops, that's indicative of no collateral flow in an area that would be, potentially, one to target for a placement and deployment of a valve. If there's continuous airflow despite the balloon inflation, then that indicates collateral ventilation, and another area would need to be targeted that doesn't have this collateral ventilation. And this is the most accurate way of determining the presence or absence of collateral ventilation. So anesthetic objectives provide excellent bronchoscopic conditions. These are procedures in which you need to have very close communication with your interventional pulmonologist. You're both working around the airway, and you want to know, you got to communicate very carefully and closely with them to ensure the best patient outcome. You want to facilitate patient comfort, maintain adequate ventilation while avoiding hypercapnia and preventing air trapping, maintain hemodynamic stability, and diagnose and manage complications. So the preferred method of doing this procedure is with general endotracheal anesthesia. It can be done with deep sedation, but everything that I've looked at and what we do is doing it under general anesthesia. You get a more secure airway. You have less distortion to collateral ventilation assessment measurements with the patient under general anesthesia. Ventilation, of course, helps in reducing any CO2 retention, and collateral ventilation assessment measurements are faster with the patient under general anesthesia. With this technique, you want to use a large endotracheal tube because you're going to be, with a bronchoscope in, you want to be able to successfully and adequately ventilate the patient, so having a larger endotracheal tube allows better ventilation. Generally, it's done with TIVA, with propofol. Some people use remifentanil. Rocuronium for muscle relaxant is most commonly used. There can be any number of ways of doing TIVA. I won't go into all the weeds on that, but it's probably the best method, I think, because when you're trying to use gas in these type procedures, you don't always have effective delivery, so TIVA allows better anesthetic conditions, I think. It's recommended that the measurement for collateral ventilation and deployment of the valves occur during the same procedure, just because there's risk in doing the bronchoscopy of inducing a COPD exacerbation, and then that would delay them getting the valves deployed if they were going to come back for another procedure. So doing it all as one procedure, measurement and deployment, seems to be the most widely recommended guide on that. Ventilation management should be targeted to reduce dynamic hyperinflation and air trapping. A longer expiratory time is beneficial because of the patient's emphysema. Here's a picture of the Zephyr valves, which are the most commonly used valves. The wider part is deployed distally, and there's a duckbill valve that closes during inspiration and then opens during expiration, so therefore air and secretions can escape, but air doesn't come in during inspiration. This is another valve that's sometimes used called the spiration valve. And this picture here shows the deployment of the valves in the bronchioles. So what are some of the complications of that? You can have pneumothorax in about 20 to 30% of patients. 80% occur in the first 48 hours, 10% in days 3 to 5, and 10% after day 6. It's attributed to the sudden expansion of the lobe adjacent to the target lobe after the treated lobe becomes atelectatic. And so the other lobe expands, and that can sometimes, in a significant number of patients, can lead to a pneumothorax. Now, not always does it need a chest drain, a chest tube, but patients certainly need to be evaluated and watched very carefully. If any signs of tension pneumothorax or hemodynamic instability occur, then certainly they would need to have a chest tube placed. These patients are hospitalized for 3 to 4 days after the procedure with daily chest x-rays and close observation for the development of pneumothorax and any problems that might arise subsequent to that. Pneumonia develops in a percentage of these patients, and they need to be treated very aggressively if that occurs. Respiratory exacerbations are common after deployment of these valves, and sometimes the valves migrate, usually as a result of being undersized or incorrectly placed. So often done in the interventional pulmonary suite remote from the operating room. Our pulmonary suite is several blocks from the main OR, and so it can be quite a haul if you need assistance from the OR. So you want to have the equipment and supplies to respond appropriately to emergencies. Patients are generally same-day admissions, so preoperative evaluation is important, as these patients, as you might expect, have significant other comorbidities in addition to their emphysema. So you want to, carefully evaluate them preoperatively to make sure they don't have anything else that, would significantly impact their anesthetic care. So with the endobronchial valves, it's found that it improves pulmonary function, increases their patient's exercise capacity, and overall improves their quality of life. We'll switch now and spend a few minutes talking about bronchial thermoplasty. This is an interventional pulmonary procedure that's performed on patients who have severe, uncontrolled asthma despite maximum medical therapy. Controlled radiofrequency energy is applied to large and medium airways with the goal of reducing bronchial smooth muscle. Asthmatic patients have a higher amount of airway smooth muscle mass compared to healthy controls, and it's felt that by reducing that airway smooth muscle mass, this will lead to improvement in their symptoms. The mechanism of action is incompletely understood. There's evidence that it acts through intervening in airway remodeling by reducing airway smooth muscle, possibly modulating the composition of the extracellular matrix. It's the first treatment that targets airway remodeling instead of modulating airway inflammation and bronchomotor tone. As radiofrequency was developed as a treatment for asthma, the intention was to have a therapy that would cause long-lasting atrophy of the airway, but not damage the mucosal layer. Radiofrequency is low in energy, doesn't damage the surface epithelium, but penetrates to the smooth muscle layer. So the goal of this, fewer exacerbation, decreased days lost at work or school, reduced emergency room visits. Bronchial thermoplasty, generally done as 3 sessions, 3 weeks apart, targeting the right lower lobe, the left lower lobe, and then the right and left upper lobes together. The right middle lobe is not treated because of concerns for stenosis of the right middle lobe bronchus and resulting bronchiectasis. It's done in a systematic manner, starting in the most distal part of the segmental airway and moving proximally to the main bronchi. Usually there's about 40 to 70 ablation activations done in the lower lobes, 50 to 100 in the upper lobes combined. The treatment bursts are for 10 seconds, and it's heated to approximately 65 degrees Celsius. So asthma, is a chronic inflammatory disease. Hallmark histologic features, hypertrophy of the airway smooth muscle, Various triggers, allergens, exercise, cold, air, infection. The major cause of airway obstruction, of course, is constriction of airway smooth muscle. So if you can obviate that, then there should be improvement in symptoms. For these patients, you want them to not have any significant exacerbation for at least 2 weeks before the procedure. They're given prednisone 50 milligrams a day for 3 days before treatment, the day of treatment, and the day after the procedure. They received albuterol, ipratropium nebulizer before and after the procedure. There can be consideration for administration of an anti-sialagogue, but some are concerned that that will delay or affect and impact negatively the clearance of secretions after the procedure. So some argue against using an anti-sialagogue. Anesthetic management can be done with deep sedation or general anesthesia. General anesthesia is the favored technique. You want to avoid coughing. Of course, sedation is difficult in patients with an increased BMI or sleep apnea, which all of these patients have. Desaturations require jaw thrust, and interrupts the procedure. So overall, doing it under general provides better procedural conditions. LMA is often recommended as the placement's less stimulating. Endotracheal tube if there's a high risk of aspiration or a difficult airway, and some people obviate for using an endotracheal tube in all of these procedures. Consider spontaneous ventilation over controlled ventilation. If you use controlled ventilation, low frequency and long expiratory times. So there have not been any airway fires reported during bronchial thermoplasty for a couple of reasons. With lasers and cautery, you get intense localized heat. They're a known cause of airway fires. The system used for bronchial thermoplasty delivers a lower controlled energy to the airway wall. The electrode tip does not heat up. So while the risk of airway fire is much less than with laser or cautery, I think it's prudent to be prepared, lower the FiO2 down to 30% during the activation period of the procedure, and use a lower FiO2, like I said, and also have water on the field, just in case. Tiva is preferred due to unpredictable delivery of volatile agents during shared airway procedures. A variety of agents can be utilized. Propofol, of course, provides fast onset and emergence. Dexmedetomidine offers sedation, analgesia, anti-sialagogue properties, minimal respiratory depression. And there was a 2012 study that's shown there, just a little bit about it, that Prop-Dex versus Prop-Remifentanil and propofol dexmedetomidine reduced airway secretions, cough, incidence of desaturations, and increased patient and procedural satisfaction. Patients can be generally discharged to home after being observed for several hours after the procedure. If they're stable, then they can go home, and then they usually come back a few weeks later for treatment of the other lobe. Complications, temporary worsening of asthma symptoms, atelectasis, hemoptysis, infection can occur. So bronchial thermoplasty, I'm almost done here, just a couple more minutes. Bronchial thermoplasty has kind of decreased in utilization with the increased advent of biologics for the treatment of asthma. Biologics are protein-based injectable meds used to treat severe asthma. They target specific inflammatory pathways. There's a variety of medications that can target various phenotypes of asthma. And like I say, that's led to somewhat of a decrease in bronchial thermoplasty. So biologics are a series of injections or infusions 2 to 8 weeks apart. It reduces inflammation in the airways, making them less reactive. And this is best for asthmatics who have underlying inflammatory triggers like high eosinophil counts. They are expensive. Thermoplasties, a series of 3 treatments, very expensive upfront cost, but then after that, it's done. And this is best for asthmatics with severe persistent asthma in whom airway smooth muscle thickness is a major factor. So that gives you kind of an overview of bronchial thermoplasty and endobronchial valve deployment. I've listed some suggested reading here that will give you further information on these techniques used in interventional pulmonology. Thank you for your time.
All right, so good afternoon. Today we'll be talking about anesthesia for robotic bronchoscopy. So what is the robotic bronchoscope? The robotic bronchoscope is...
It's unique sensing technology enabled. It's unique sensing technology enabled.
I'm just gonna stop that here. So the robotic bronchoscope is a very thin bronchoscope. It's 3.5 to 4 millimeter. It can accommodate up to a meter long instrument, so it can go very far down in the lung. So the regular bronchoscope can only go down to the carina first and second bifurcation, while the robotic bronchoscope can go very far out in the lung. And it's very malleable. The regular bronchoscope only binds forwards. This can bind in every direction you can imagine. So they basically invented that to go as far as they can in the lung, biopsy any lung nodule in any place in the lung. So how do they do robotic bronchoscopy? So the patient gets a baseline CT scan. While they're awake, they tell them to take a deep breath. They find a nodule on the CT scan and they say, okay, we want to biopsy that. So they get the CT scan, they load it into the robot, and the robot creates a 3D airway image that tells the pulmonologist how to get to that lesion. So if you go down this airway, next that airway, and then you'll get to it. So this is called planning for the robot. That's the first thing they do, and then you get the patient in the bronch suite. You put them to sleep under general anesthesia. They dock the robot.
You might qualify for this
so
new
that's what
2025
happens.
window replacement
Sorry, I should have
service.
put this. And then once they dock the robot, they insert it into the ET tube. And from there, they navigate to the lesion based on the 3D picture that the robot has created. So this is what the robot is telling them. And this is the picture from the bronchoscopy where they see where they're going. Once they get there, they do a CT scan to confirm that the robot is going towards the lesion. So if this is the lesion, there is a CT scan that tells him, okay, you're right at the lesion. And once they get there, they insert a needle, which is the smaller needle here, to make sure that you're actually inside the lesion. And from there, they do another CT scan, and then they do fine needle aspiration of that nodule or tumor. They send that for pathology to tell them if this is cancer or different other diagnoses, or they're not getting good samples. So this is what they do. So why do they need us? They need the patient to be still. Basically, they don't want the patient to move during all these CT scans that they're doing because it will give them motion artifacts. Also, coughing can lead to problems with their ability to navigate, and also it can disconnect the robot, so they have to start over from the beginning again. So basically, no coughing, no movement during the whole procedure. So how do we do anesthesia for that? So when they first introduced that to MD Anderson, when they worked, we decided to follow the same techniques we use for all the procedure, TIVA. So we use propofol or curonium. I don't tend to use much narcotics. There is some sympathetic stimulation when the robot goes into the airway, and we ablate that with lidocaine. We don't really use any narcotics in these procedures. Sometimes we use sevoflurane. If the patient suffers from bronchospasm during the procedure, we just turn the propofol off and use the sevoflurane instead. We intubate generally using the bronchoscope, and the reason for that is that the pulmonologists like to see the airway to make sure that there is no pathology from the vocal cords down to the carina. So if you intubate with a laryngoscope, they miss that part of the airway exam. So they prefer that we show them what's going on in the trachea before they go in. You can also use the video laryngoscope if that's easier for you. The trick is to avoid multiple attempts, avoid bleeding, because if any blood trickles down towards that lesion, it's going to be obscured by that blood and it's going to make the navigation difficult. So use whatever is easier for you. AT tube size, a little bit more about that later, but you usually use 7.5 for women, 8 for men. The reason for that is at the end of the procedure, they sometimes want to do ultrasound to do staging of the mediastinum. The EBA scope is quite big. It does not fit well in anything smaller than that. Also, the therapeutic scope, sometimes they use it for the airway exam at the beginning. It does not fit in any tube that is smaller than 7.5. So you need to know what kind of scopes they're using during the procedure. Sometimes we use 8.5 or 9 tubes, and that's only if they're telling us that there is a big blood vessel going through that nodule that we're going to biopsy. It might bleed. So it's much easier to put the therapeutic scope through a bigger tube and pull blood clots. So if they have this kind of issue, we tend to put bigger tubes from the beginning. Also, if they want to do the staging EBUS and we don't want to put an element in that patient for one reason or the other, we prefer to use a bigger tube because it's easier to ventilate with the bigger tubes. Just bear in mind, patients who are small, less than 40 kilograms, or patients who have severe COPD and saber sheath trachea, inserting these big tubes can be a little bit traumatic to the lining of the trachea. So a little bit nerding around here to figure out, you need to know what scopes they are using and what tube you need to use. So it's very simple. You can measure the cross-sectional area of the ET tube that you're using by using the simple formula for cross-sectional area. You can also use measure the cross-sectional area of the bronchoscope they're using. And when you subtract that, you get the area that you're actually going to be ventilating through. And from that, you can extrapolate what size tube is that equivalent to. So if you try to use 5, 6, 7 tubes, basically the scopes really will not fit at all. If you use an 8 tube, you're left with a ventilation area that is equivalent to 4.8 ET tube. And if you use the 8.5, you have ventilation space equivalent to 5.5 tube, and the 9 gives you a 6.3. So you need to know really what they're using to decide what size tube you want to put in. We started doing the anesthesia. We were very excited, and then we ran into trouble quickly. We found out that some of the lesions that are located posteriorly in the lung, once the patient goes to sleep, atelectasis sets in, and then you can't see the lesion. They can't navigate to it. They don't know where they're putting their needles, so they're basically shooting in the dark. So a little bit about atelectasis. Atelectasis is known to happen in 10 to 15% of the lung tissue in 90% of patients. And there's different types of it. Compression atelectasis happens in the dependent areas of the lung and near the diaphragm. And that's because of the decrease of the FRC in the supine position. So your normal FRC is about 3 liters. When you lay flat and you're awake, it decreases by 0.7 to 0.8 liter. And then when you put on top of that general anesthesia and paralysis, you lose another 0.4 to 0.5. So loss of the FRC leads to the atelectasis under general anesthesia. The second type of atelectasis is absorption atelectasis when you use 100% FiO2. This doesn't happen unless you have a complete obstruction of the airway by a mucus plug or you have a bronchoscope wedged in there. What happens is the oxygen behind gets absorbed and doesn't get replaced, so that area gets atelectatic. But if you don't have an obstruction, there is no atelectasis with 100% FiO2 because there is a surfactant that keeps the alveoli open, and also you keep ventilating so that oxygen gets absorbed and you give a next breath. So you have to understand the difference. Also, another source of atelectasis for bronchoscopy is they go in, they do an airway exam, they suction all the secretions so they can navigate in a clear pathway. That suctioning can cause quite a bit of atelectasis. So it is an evil that we couldn't really get away from. So another problem with atelectasis, it created that phenomenon you might hear about called CT body divergence. So if you have a nodule located here and then you put the patient to sleep, they get atelectatic, the size and the shape of the lung changes, so the nodule location moves. So the robot has designed a navigation pathway that leads to here, to the blue nodule, but it's actually moved down in location to the orange nodule. So now they're navigating to a wrong place and the needles are going in the wrong place. They were able to get rid of this problem by doing CT scans after the patient goes to sleep, and then they had an integration software that actually relocalized the nodule in the asleep patient and then recreate a navigation pathway. So they were able to get rid of that problem by changing the software in the robot. But we were still left with the atelectasis. So there were a few studies that were looking at the incidence of atelectasis. So atelectasis happens in about 40 to 75% of the patients, and in about 1/3 of these patients, if the lesion is in the atelectatic area, you really can't see it and you can't get to it. So this is the incidence of the problem. And then we try to figure out where in the lung this problem really exists. So the lower lobes have the highest rates, 70s and 50%, followed by the middle lobes. And then atelectasis gets worse the longer the patient is under general anesthesia and the bigger the BMI, which is kind of understood. So how do you figure out if this patient is going to get atelectatic, is going to mess up the procedure for the bronchoscopist? So if you imagine an imaginary line that runs on top of the spine, anything below that most likely will get atelectatic. So if you have a nodule in that location, just you have to figure out what to do with it, because your likelihood of having a successful procedure goes down quite a bit. So 2 major studies came out to try to figure a way to get around this atelectasis. The first one is VESPA trial, which happened at my institution at MD Anderson. And the second one, the LNVP study, which came from a private practice spearheaded by Dr. Badra. So the VESPA study was a randomized controlled study, and the LNVP was a retrospective study. Our study decided to use the protective lung volumes of 6 to 8 cc per kilogram ideal body weight. Dr. Badra's study went to 10 to 12, hoping to inflate the lung and get rid of atelectasis. We used 8 to 10 of PEEP, and the reason for that was because the closing capacity of the or pressure of the alveoli is about 5 to 6 centimeter water. So we just wanted to go a little bit above that to avoid overinflating the lung, but stay above the pressure that will close the alveoli. Dr. Butters used 10 to 15 centimeter water of PEEP in the upper and middle lobe, which didn't make a lot of sense because these areas do not really get atelectatic, so there was really no reason to put such a high PEEP in there, and use 15 to 20 centimeter water of PEEP in the lower lobes, which made sense, but it was a little bit overboard. If the alveoli just need a little bit above 6 to stay open, why do we need to go to 20? So both studies used lower FiO2 to keep the SAT above 94, but our study said if the patient desats and you can't do it and you need to use 100% FiO2, by all means, just use it. The atelectasis rate lowered down from 37, 35 to 28 and 27 in the other study. So they were able to decrease the rate of atelectasis, but they could not really eliminate it, both studies. The diagnostic yield came up from the 80s to 90% and 92% in the LNVP study. There was no pneumothorax in both studies, but Dr. Badra's study had another problem, increased respiratory motion. Because they're using very high tidal volume, the nodules were just moving up and down, and the robot is designed to stay stable even if the lung is moving, so they were targeting a moving lesion. So that was a big problem that came out from this study. So if you want to know about respiratory motion, the upper ribs usually move outwards and upwards, and the lower ribs move just lateral. And the excursion of the ribs in the lower areas is a lot more than the upper areas. The diaphragm moves down. So when you use higher tidal volume, there is increase in the expansion in the respiratory motion, which makes the navigation and the targeting of the nodule very difficult. So if you look at this, the movement of a peripheral nodule, usually between full aspiration and full expiration is about 17.6 millimeters, and it can reach up to 60 millimeters if you are in the lower lobes. So if you look at this video, so if you look at the diaphragm, this is excursion of the diaphragm at 5 cc per kilogram tidal volume. Now, if you have the same patient and you increase the tidal volume to 10 cc per kilogram, you see the excursion of the diaphragm increases quite a bit. So if you imagine a nodule is moving that much, there is really not a good way to target it. So that was their problem. So they came up with a second study to fix that problem, where they recommended doing apneic breath hold for these cases. So what they were doing was breath holding for 4 to 6 minutes, and then ventilating for 30 seconds in between. And they would breath hold during the navigation, which takes about 5 to 10 minutes, during biopsies, which can be 5 to 15 minutes, and during the CT scans, which could be 5 to 6 CT scans. Each one of them is about 2 to 3 minutes. So you can imagine the amount of breath holds that they were doing for these patients. And worse than that, during the breath hold, they will dial the APL valve to the same PEEP that they're using for the procedure. So the APL valve could be at 20 centimeter water while the patient is in breath hold. So it's almost like a halfway to Valsalva here, which was quite a bit. They also used the lower FiO2 for that study. So this is the pictures. This is an awake CT scan. This is just a regular ventilation parameter. You see that atelectasis everywhere. And this is the same baseline awake CT scan. And this is with the hyperinflated lung. You see the lung is quite black, but they're able to reach lesions in the back of the lungs without any atelectasis. Unfortunately, as expected, 67% of these patients required vasopressors. So they used phenylephrine, ephedrine, and norepi. And 90% of the patient had to get about 1 liter of lactated ringer IV fluid bolus to handle the hypotension that happens. And the diagnostic yield was lower. So we went from 92% to 85%. I'm really not sure why, but the diagnostic yield was lower. So if you compare these two studies, they both were able to decrease but not eliminate atelectasis. The VESPA study parameters used more lung protective volume, lesser PEEP, and no breath holds, and more hemodynamic stability, and got the same rate of atelectasis. So there was really no need to go all the way to the other parameters that hyperinflated the lung and caused a lot of PEEP. There is no head-to-head comparison between these two studies, and both studies said that they're safe. There was no pneumothorax, but if you talk to people who are using the LNVP study, there were incidences of bradycardia and even cardiac arrest that were not reported or published, but people talk about it among themselves. And we really don't know what is the reason for that. Is it the high PEEP or the high PEEP leading to air embolism when they try to get the needles into the vessels in a hyperinflated lung? But this is happening, and I don't know if you guys came across it. I haven't seen it at MD Anderson, but this is something to be careful with if you're using the LNVP parameters. So we decided to look at something else to fix the problem with atelectasis. So we tried the lateral decubitus. So again, you have a lesion in the back of the lung, gets atelectatic once the patient goes to sleep. We flip them on their side, and lo and behold, the atelectasis is gone, the needle is in the lesion, and there's no problem navigating and biopsying. So even if you have severe atelectasis in the supine position after you intubated the patient, once you turn them, it goes away. So when these studies started to come out, they were saying you have to intubate really fast and use rapid sequence induction, and whoever can intubate the best should go for it. You really don't need to rush intubation because atelectasis is going to happen no matter what. All you have to do is just turn the patient, it's going to go away. So it's a little bit more relaxed induction. The patient lay on the side, the lower arm is bent, and we wrap it in a towel, tuck it under the pillow or the mattress to hold it in place. The other arm is on top. So it's usually move the blood pressure cuff from the upper arm so it doesn't read much lower than needed. We usually put it in the leg, and if you have your IV here, you can just need a little bit of an extension. So it's really very simple to do. There is other positioning suggestion, the reverse Trendelenburg. So if you have a lesion that is sitting right above the diaphragm, and you know there is a lot of diaphragmatic movement, and also there is a collapse of the diaphragm and more atelectasis in this area. When the patient is paralyzed, you can just turn the head down, and you just add a little bit of PEEP, and you use low tidal volume to decrease the movement of the diaphragm so the lesion is not moving a lot. You can still use 100% FiO2, and you see the lesion here seemed like it was stuck on the diaphragm. You can actually see the space between it and the diaphragm in a reverse Trendelenburg. Dr. Badra also came up with the prone bronchoscopy. So if you have a lesion sitting back here, you turn the patient, now the spine is up, you can see the lesion here and no atelectasis. We don't do prone bronchoscopy because we were concerned about if we have bleeding, if the tube comes out, it's going to be really a hassle to undock the robot and turn the patient and take care of them. But he has published the prone positioning for robotic bronchoscopy. So when to use these ventilatory parameters? So after they dock the robot, we give a couple of recruitment breaths to reverse the atelectasis that happened during the intubation and the airway exam suctioning. And then we add the PEEP and adjust the tidal volume respiratory rate. We put the APL valve at the same PEEP that we're using. We generally use about 5 of PEEP, which is just within normal limits for any ventilation. And then when they ask for the breath hold, you do the breath hold at the peak of inspiration, and you have the APL valve dialed at 5 so the lung stays up, and make sure the patient is paralyzed because they don't want him to move during the CT scan. So some of the problems you might encounter during these procedures, bronchospasm happens in about 10 to 12% of the cases. The problem with it is they want to navigate far out in the lung, and the patient is bronchospastic, the robot can't go because the airway is very tight. So you need to take care of it. Usually it's from irritation, from what they're doing, or the patient has baseline COPD or reactive airway disease. But anyway, you have to detect it quickly and deal with it. So you can detect it by the changes in the shape of the CO2 waveform. You can also change from TIVA to sevoflurane, or you can give albuterol through the working channel. So this is a little trick we use at MD Anderson. You put your albuterol in a 60 cc syringe, and you put it in the working channel up outside, and then you have the tip of the bronchoscope above the carina, and you can actually use the plunger to push the albuterol inside the airway. So you're sure it's getting in there. You're not going to be able to do this with the robot docked. So if you don't have the ability to give albuterol right away, you just switch to sevoflurane, and you change your respiratory rate to a lower rate and the I to E ratio to increase exhalation and avoid air trapping. Few other things to know. Atelectasis does not happen in patients with severe COPD because their lungs are quite stiff, and they have O2 PEEP, so they stay open. So you really don't have to worry about all of these things in somebody with severe COPD. Also, the lung is hyperinflated and the diaphragm is pushed down, so there's not a whole lot of movement down there either. So they're a little bit different than the rest of the cases. Other patients to worry about, people with RV failure, pulmonary hypertension, they can get in trouble with the high PEEP, can get severe hemodynamic instability, so be careful around these patients. Also remember, atelectasis does not happen with 100% FiO2 in the lateral position, which enforces what I said, that absorption atelectasis need an obstructed airway to happen. It doesn't happen in an open airway. So, and then the lateral position and reverse Trendelenburg can actually help you get rid of that atelectasis. One last irritating thing is they don't want any wires hanging below the table, so you just have to be careful that all the wires run along the mattress or the bed, so when the C-arm rotates, they don't get tangled in our wires. Now you think I'm done, and we got to the lesion, we done biopsy. Now they said, okay, we got lung cancer, we need to stage the patient, so we're gonna do endobronchial ultrasound. So what we normally do for that is we get rid of the PEEP on the vent, we remove the AT tube, and we put an LMA. We usually use the iGel. The iGel LMA, we usually use size 4, and just on a side note, we choose the iGel size based on the patient height, not weight, because when you gain weight, your larynx doesn't get bigger. When you're taller, you have a bigger structure and your larynx is bigger. So people who are taller than 6 feet get the 5. People who are smaller than 5 feet get the 3. Most of the population would fall between 5 and 6, and we use the 4 in most of our patients. Why we use the iGel? Because of the ability to suction the stomach. And also it has a built-in bite block, which is very good for bronchoscopy. We limit the peak airway pressure on the vent to 20, so we don't blow air in the stomach during the use of the LMA, and that just wards off any aspiration. So this is the end of my talk. Looking for any questions.
Thank you, everyone, for patient listening, and thank you, Mark and Mana, for excellent presentation. I have one question. As I said, I used to work in Penn Medicine until about a year and a half ago, and then moved to Jefferson, where we were doing lots of these navigation bronchoscopic procedures. And when I started there, I noticed we were not really sticking to any recommended ventilation parameters. Most of them got standard, near 100% oxygen for induction, followed by about 50 to 60% FiO2 for the rest of the procedure. PEEP was, administered about 8 to 10 centimeters of water, and the tidal volumes were what's kind of recommended. I looked at the data after getting an IRB approval, and of all the things that were recommended, the only thing we kind of got it right most of the time was a recruitment maneuver, followed by PEEP, which we got it right in about 80% of the patient. But FiO2 was off the chart in every patient. Only about 3% of the patients had what is recommended FiO2. But in spite of that, what we found was diagnostic yield was 98%, and navigation success, our ability to approach the lesion, was 100% in these 224 patients. So my question to Dr. Sarkis is how we could achieve it. And the lesions were all over the place. It is not just they were upper lobe or lower lobe. About half of them were on the right side, 1/3 of them were on the left side, and many of them were bilateral lesions. So it could be our pulmonologist is very good, success rate is very high, or is it something more than that? Or these guidelines are basically irrelevant?
So as I said, the main issue is lesions in the dependent areas of the lung. So the first thing you need to do when you look at these studies is, did I have atelectasis? Did the atelectasis obscure the lesions? Was the pulmonologist unable to see the lesion? So that's number one. Number two is you have to get pictures of the needle in the lesion to be able to say that my navigation, my procedure was 100% successful. If you don't have a picture of a needle in the lesion, you cannot say that. Number four, the diagnostic yield is defined by the ATS and the acquired study as having an actual diagnosis. So if you have benign as diagnosis, if you have atypical cells as diagnosis, if you have bronchial cells as diagnosis, that is not 100% diagnostic yield. To have a 100% diagnostic yield, it either has to say this is small cell cancer, non-small cell cancer, lymphoma, histoplasmosis, sarcoidosis. If you don't have a defined diagnosis, you cannot say that I have 100% diagnostic yield. So the definitions are a little bit tricky. You have to figure out your rate of atelectasis. We cannot say that we had 0% atelectasis because I don't think it's true. We have to also know in those patients who have atelectasis, how many of these the lesion was obscured and how did that affect the procedure. So without this data, it's very hard to define these things. Again, these parameters are useful for nodules in the posterior part of the lung and for patients who are obese or under anesthesia for a long time. They don't really apply for severe COPD. They don't apply for somebody who weighs 40 kilograms. They don't apply for upper lobe lesions. So you have to be selective and understand what these studies were targeting.
And I have a question to Mark. We had one pneumothorax, in fact, tension pneumothorax after valve placement. And what's your literature says and what's your experience? Risk of tension pneumothorax or pneumothorax after valve placements for?
It's the risk of pneumothorax is significant. I mean, you read a wide array of numbers, anywhere from 4 to 30%. The number that developed to a tension pneumothorax is significantly less than that. So a lot of the pneumothoraces can be observed, and some will, go away on their own. But if there's any sort of hemodynamic change, or if it's, complete pneumothorax, then certainly placement of a chest tube would be indicated.
So something we need to watch out for.
Yeah.
Good 48 hours.
Yeah,
okay.
They watched them in the hospital for about 4 days after valve deployment.
Anybody has any questions? Yeah.
What if your health system says, we want to transition this from the hospital to an ambulatory surgery center? What advice can you give your anesthesia colleagues to have these discussions with the hospital administration to make sure you have the best resources and the best opportunity for patient safety in this situation? Because we're becoming more and more outpatient cases for some things and not for others. So what advice can you give?
In fact, we were just discussing this before we started the talk.
So at MD Anderson, we have two standalone surgical centers that perform interventional pulmonary procedures. We do robotic bronchoscopy, we do e-buses in there. We do not do rigid bronchs or stent placements in there. So the problem with these centers is they don't have blood banks and they don't have, they have hospitals near them that they can transport the patients to if they need to, but they're quite far from the main campus, MD Anderson. So using our protocols and our techniques, really, we were looking back at the cases we've done in interventional pulmonology. We had really one pneumothorax in the past 4 years, and it didn't even need a chest tube. So the procedures are quite safe if you really know what you're doing and using the right parameters. Having said that, we also have criteria to what patients can be done in these locations. So based on the Society of Ambulatory Anesthesia recommendation, based on the patient's weight, if they have difficult airways, if they have pacemakers or AICD, they are shifted to the main campus. So we do have our own patient selection criteria. We do have very safe procedures. We don't allow everything to be done there. But looking back, and we're actually going to publish the data, it's been quite safe to do robotic bronchoscopy and e-buses in these locations.
Yeah, and another observation I have is, you're required to be doing significant number of these cases to have high success rate and safety. So I don't know whether a small ambulatory surgery center can get sufficient volume to do these kinds of advanced procedures. Even in major hospitals, we don't do that many. I mean, for example, in Jefferson, which covers 30% of the catchment area in the Philadelphia region, we probably do about 100 a year. Yeah.
You spent a bit of time talking about atelectasis and prevention of it. At our hospital, we don't have intraoperative CT scans, so I don't know if that is how you would measure like the improvement in atelectasis
Right.
But no one's ever said, aha, it's atelectasis.
So the CT scan is the gold standard to find atelectasis and make sure when you get rid of it, you can see that it's gone and you can see a needle in the lesion, which is really what they need. The other way to see it is the radial probe EBUS, the one that rotates 360, but it's very misleading because it can also, if that probe is in an atelectatic area, you would, when you look at it, you cannot tell if that's the lesion or atelectasis. So it is a little trickier without the CT scan. The CT scan have become available, I think, in the past couple of years. Not all centers bought one because it's quite expensive. But without the CT scan, your likelihood of success and knowing what you're doing and actually seeing a needle in the lesion and getting a good diagnostic yield is not as great. So I think they're moving more towards CT scans.
Yeah.
Thank you. Great talk, thank you. So outside of the advanced procedures, I have more of a bread and butter question. I guess the culture at my center has always been to have a spontaneously breathing patient where we do the bronchoscopy with like general anesthesia, natural airway kind of thing. A lot of my colleagues at other centers put a iGel LMA. Just curious, do you have thoughts on what gives better operative conditions for the bronchoscopist, or any insight there? Is it dealer's choice kind of deal, or what do you think?
So anything other than the robot, we use an LMA. And the reason for that is you have an airway. If the patient becomes hypercarbic, bronchospastic, any problem, you can deal with it. You have access to the airway. You don't have to, rush and figure something out. So we prefer the LMA. We also paralyze the patients with the LMA in place, and we keep the peak airway pressure limited at 20, so we're not opening the lower esophageal sphincter and we're not getting air in the stomach. So we don't really have aspiration with LMAs. Also, keeping the head up a little bit helps. I prefer to have an airway than not to have an airway. I think the ET tube is not the ideal airway for interventional pulmonology because it obscures a lot of the trachea. They can't see any pathology in the trachea. It limits the movement of their bronchoscopes. So it's not really, it doesn't create the best conditions for them.
I think an LMA is useful for most procedures, like routine sort of therapeutic bronchs, even those that we do that we're involved with, I use an LMA a lot.
We have Dr. Teja Gann if he wants to add anything.
It's my boss.
Okay. All right.
What about the AT radio frequency with a pacemaker or another device?
That is often times recommended against using that technique in patients who have implanted devices.
All right. If you don't have any questions, we will call that off. Thank you so much. And thank you, Mark. And